And welcome back. I'm Mabel Jong. This is WHCC TV, and we are on day 4 of the World Healthcare Congress. Thanks for staying with us. We hope you've enjoyed the programming. Next up, Iora Health. Iora Health is a Boston-based, team-oriented Medicare Advantage primary care provider. The model focuses on relationships with care teams that include physicians, health coaches, behavioral health specialists, nurses, and finally, a manager, working as a team to treat the whole patient. We have in the studio CEO and co-founder Rushika Fernandopulle, and I'm so glad to be able to see you again, Dr. Fernandopulle. You said your model works really well, and perhaps even better for people who are sicker. Now, why is that?
So our model at root is based on relationships, not transactions like the current healthcare system. I think for people who are sicker, particularly who have chronic disease, the model is maybe the only way to take care of them. Thinking you can take care of chronic disease in these transactional models doesn't work. So we focus on older, sicker, chronically ill folks. Okay.
We had the privilege of really speaking with you when Iora Health was just a baby, if you will. And fast forward to where we are now, what are you most excited about the growth that you've had these years?
So I think one is that we've really started getting to scale. When we started this, people said, oh, it's fine to do 1 or 2 little cute pilots, but can you really scale this across the country to different sort of markets? And we have. So by the end of the year, we'll have over 50 practices in 12 different markets that are very different from each other. Houston, North Carolina, Seattle, Phoenix, Denver, Tucson, Hartford, Connecticut, Boston. So they're all very different places, and but the model works. No matter where we go. So I'm very proud of that. The fact that we are have been able to, really show that there's a better way. Probably the thing that makes me the most proud, though, is that I started Iora because we wanted to transform healthcare everywhere. And it was sort of the Southwest Airlines theory of change, right? So U.S. Airlines, 1980, high fares, poor service. What changed? It wasn't the government or consultants, or to be honest, American and Delta waking up and deciding to be better. It was a new entrant coming in, doing something very different, and getting customers to vote with their feet. And that not only gave those customers better experience, lower fares, but sort of kicked the incumbents in the behind. So we're starting to see that, where we're seeing more and more incumbents, big health systems, starting to try and copy us, which is exactly the right thing.
Well, when you first emerged on the scene, you were considered a real disruptor. Now, years later, are you still considered one? Because what has really changed around you as you've grown?
So I think when we started this, I started doing this 15 years ago. The things we talked about, which is value-based care, consumer-centric, we need to be digital, were thought of as crazy. Now they're sort of established as what we ought to do. So if you know, last week CMS had a big announcement that they want to move 1/4 of Medicare beneficiaries to models like ours, with some version of a fixed fee payment, with team-based models, with outcomes and not more processes. So it's becoming much more mainstream now, which is great.
That's tremendous validation for you. But are you discouraged by the rate of change, the pace of change? Because people know they can do this, but yet we're still looking at healthcare costs at astronomical levels. We're still looking at pharmacy costs, drugs costs at incredibly high levels. So we're still paying a lot for our care.
We are, and I think, to be honest, we have not just, a lot of what we've done up to date has been sort of what I call futzing around the edges, right? In the end, if we don't change how actual people get actual care, it's all a waste of time. I think a lot of the last generation of efforts, many of the ACO models, many of the medical home models, didn't really fundamentally change how people got care. They were change a few things around the edges. And I think what we and a few other people are doing now is saying, no, we need to fundamentally change how the production process itself. Then we have a shot at actually changing outcomes.
Where should people start?
So I think they should start, so the fundamental different thing what we do, typical practices, they think their job is they walk in the door and then they see one patient at a time, do the best job they can, they turn their brain off, go to the next one. I think that the only way we're going to fix healthcare is do what we're doing, which is find populations of people to serve, know exactly who those people are, and then do whatever it takes to improve their health and keep them out of trouble, right? So I think it is running not slowly toward these new value-based payment models, but fast, right? Because you cannot do this sort of care redesign with the current payment. There are now opportunities to do this, and I think the hardest thing, I think, is going to be the transition from where we are now to where we're going tomorrow. And I think the mistake a lot of the market's doing is they're trying to do that slowly.
Okay.
Right? And we hear this sort of foot in each canoe. I've got a foot in the dock, a foot in the canoe.
Okay.
That's a bad place to be.
Okay.
So I think the institutions that will be successful are the ones who just decide we're going to move to the new world and we're going to go there fast.
Okay.
And now we have a shot.
Okay. So it's almost like Iora's an old timer now. So any other big plans on where else you want to take Iora?
Is we're always trying to figure out how we make the model better. I think one of the things we're starting to think about is can we take some of the things we've learned and some of the things we've built and offer it to other folks, you know, who are running their own sort of practices, but who could use some of the things we've built and learned over the last many, many years as partners in this.
Any plans in expanding from not just the Medicare population, but to a wider community of members?
Yeah, so we've always actually, while the bulk of our patients are in Medicare, because I think Medicare and Medicare Advantage works so well with this model, but we continue to serve other patients too. So we work with a number of self-insured employers, folks like the Boeing Company, unions like the Washington Teachers Union, Dartmouth College employees. So we serve a number of employer populations. We still have a few clinics which are actually doing this retail. So we have a clinic in Jackson Heights, Queens, with a great organization called Green America, where it's a micro-lending company that gives loans to poor women, typically undocumented, and it's sort of $1 a day primary care, where they pay us $30 a month to get this. So we have a variety of populations we serve, and we'll be expanding out in all of those.
All right, thank you so much. And may I ask how the conference is going for you this year?
So I think conference is great. I always think it's a great opportunity to see people I haven't seen in a while, to hear some really great ideas. So I've really enjoyed it.
All right, thank you again.
Good, thank you, Mabel.
And thank you for watching. Stay with us.